Hello, I'm Christoph Corell. On behalf of CME Outfitters, I would like to welcome and thank you for joining us for episode 1 of this 3-part CME Snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Today's episode is titled Schizophrenia as a Whole Body Disease, examining the impact of comorbidities on morbidity and mortality. The CME Snack series is supported by an educational grant from Alchemies and is brought to you by CME Outfitters, an award-winning, accredited provider of continuing education for clinicians worldwide. Again, I'm Christoph Corell, professor of psychiatry and molecular medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell in Hempstead, New York. And I'm very pleased to be joined today by Diana Perkins, professor in the Department of Psychiatry and director of OASIS at the University of North Carolina School of Medicine in Chapel Hill, North Carolina. She's also the director of early psychosis interventions in North Carolina. Welcome, Diana.
Thank you, Christoph. It's my pleasure to be here.
Great to have you, and I'm looking forward to the discussion. To frame today's episode, let's start by reviewing our learning objective, which is to employ best practices for the management of patients with schizophrenia at high risk for adverse events and also for inherent cardiometabolic problems. Diana, let's begin our discussion today with a relationship between mortality and comorbidities in individuals with severe mental illness.
Well, Christoph, I know you're aware that compared to the general population, persons who have serious mental illness, especially schizophrenia, have a 10 to 20 year reduction in life expectancy. And that we also see that the gap in life expectancy has actually been widening over the past decades rather than narrowing. So that's just, I think that those trends are highly concerning, and we need to pay attention to the underlying causes of this increased mortality.
Yeah, that's really a big problem. People are not just hit by the mental illness, they are also hit by physical disorders. So what have we learned about medical comorbidities that are often observed in these individuals with severe mental illness, particularly schizophrenia?
Right, so we know schizophrenia is associated with elevated rates of smoking, obesity, metabolic syndrome. And of course, these are also risk factors for cardiovascular disease, for diabetes, for chronic obstructive pulmonary disease. And in addition, individuals with schizophrenia have increased mortality from infectious diseases. More recently, there's been evidence that people with schizophrenia, in fact, are more vulnerable to COVID-19 disease and have increased mortality. So it's sort of across the spectrum of illnesses. Individuals with schizophrenia appear to be more vulnerable. And when we look at the leading causes of death in persons with schizophrenia, well, it is chronic obstructive pulmonary disease that leads the pack. However, we also see other disorders such as complications of influenza, diabetes, cardiovascular disease. And so in addition to these risks of suicide and accidents, it's really these somatic illnesses that are the main contributors to this increased mortality.
So basically, people die of the same things like the general population dies, but they die from them earlier and they have a higher propensity to get these disorders, the somatic illnesses. And there seems to be a complex interaction, correct? So there might be some genetic distribution or contribution. Some first episode patients, even without any treatment, have dysregulated glucose functioning and insulin sensitivity. Then there is the unhealthy lifestyle that is added because patients might actually be so sick that they don't follow the healthy lifestyle instructions, that they don't take medications to treat these illnesses. But also, our medical system doesn't treat these severely mentally ill patients as well as to the general population from the medical comorbidities. And we'll get into all of these contributions during this program.
Absolutely. I think you just had a nice summary of it. And I think one of the underlying problems is that schizophrenia is not just a brain disorder, it is a multi-system disorder.
Yes, so thank you for saying that. So clearly schizophrenia is complex and multifactorial, but it's also accompanied by a multi-system dysfunction. So I want to just briefly remind our audience of the clinically relevant domains in schizophrenia. We all know about positive symptoms, clearly, because that's what our current dopamine blocking medications work for: hallucinations, delusions, thought disorder, hostility, excitability. But we also have mostly unaddressed negative symptoms, cognitive symptoms. Some of our newer antipsychotics don't cause secondary negative and cognitive symptoms and don't really worsen the motor symptoms, of which some might be inherent even to the dopamine dysregulation that is associated with schizophrenia. Even before antipsychotics, tardive, or not tardive, but dyskinetic movements were actually observed. We also know that patients can get quite depressed, might have anxiety and be suicidal. And fortunately, some of our newer agents can help the depression by being also antidepressant in action. But then there's the physical mortality and morbidity that is partially due to the illness and behavior, but also our medications can have varying degrees of worsening the metabolic burden. So Diana, individuals with first episode psychosis actually do show abnormalities in several organ systems, don't they, that are going beyond the CNS. So these abnormalities are thought to contribute to the excess mortality. What are your thoughts about that?
I think we're seeing that, for example, schizophrenia is associated with elevated oxidative stress. And oxidative stress is actually a vulnerability factor for cardiovascular disease and diabetes. So it may be that what the underlying pathways that are dysregulated in schizophrenia may be contributing both to the brain disorder, the brain symptoms we see, as well as the cardiovascular risk and diabetes risk. And so oxidative stress is one of those. We also see evidence of elevated activation of the immune system. So you can call that pro-inflammatory, although it's a complicated picture. But we definitely see alterations in immune system biomarkers that are associated with schizophrenia risk are higher in persons with first episode psychosis. And these are also the very same biomarkers that drive cardiovascular disease and diabetes risk.
Wow, that's a really complex picture, isn't it? It's a multi-system, multi-organ disease that is somewhat intertwined, but might also be separate. And maybe some of the immune dysregulation is also related to in utero infection that could lead in part to a subgroup of people with psychosis. But another way to look at this data that you just described and the different components is to create a heat map of the effect sizes of associations of these underlying or associated issues in terms of immune, hypothalamic pituitary, adrenal axis problems, cardiometabolic, brain structural, neurophysiological, as well as neurochemical problems. But what does it actually mean for the patient? Well, it means that they might be more prone to get an infection, as we just said, or you said before, COVID-19. It could also be because their lung system and their smoking is really vulnerable. They also die more from chronic obstructive lung disease and its complications. But the brain structural problems might be related to problems with cognition, also knowing how to navigate socially the system. They might not have as much verbal fluency so that people actually recognize that they're different. And as we mentioned, the oxidative stress, inflammation, and metabolic abnormalities makes patients vulnerable to dying early. So how do these non-CNS alterations in first episode psychosis relate to the potential role in the pathogenesis of schizophrenia?
I think you're making great points, Christoph. And I'm just noticing that all of these are tied to stress axes and stress vulnerability. So the hypothalamic pituitary axis, the immune system dysregulation, these are tied to both the cardiovascular disease vulnerability as well as schizophrenia. So I think we can also kind of think of this as the problem with stress vulnerability and stress reactivity, maybe one of the underlying drivers for both the somatic as well as the psychiatric morbidity.
Yeah, that's very well put and well taken. So that also means that we need to help patients to modulate and mediate stress so that they are not as affected by it. And sometimes medications, obviously, can also be one factor to reduce the stress inside and outside. And hopefully in the future, we get some medication that can directly modulate the immune dysfunction or inflammation. But let's go to the different models that one can think about when there's this interaction between CNS abnormalities and non-CNS abnormalities. So there are three main models one can think about. There could be risk factors that then are mediated through non-CNS dysfunction that expresses itself ultimately both either as a CNS dysfunction or non-CNS problem. It could also be that the main problem is in the CNS. The risk factor has a problem that creates a problem in the CNS. And then we have psychotic symptoms that secondarily have problems with non-CNS dysfunction. And finally, there's also the third model that transposes this back into in utero, where there are risk factors and they both are expressed in parallel to non-CNS dysfunction or CNS dysfunction. At the moment, we don't really know which way it goes, but it just says we need to address both the CNS and non-CNS consequences of the illness. And as we get to the etiopathology, hopefully we can map some interventions to each of the risk factors and its expression. But Diana, as you know, obesity is highly prevalent in schizophrenia, and it's one of the core functions and dysfunctions that can lead to syndrome X and metabolic syndrome. So what are some of the implications of obesity on brain structure in first episode psychosis?
So Christoph, I think this is an example of where these problems with the fundamental biology, whether it's immune system dysregulation, the stress reactivity access, it forms sort of an iterative downward loop where, for example, obesity impacts brain function and brain structure, actually in all humans, but that people with schizophrenia may be particularly vulnerable to this, to the impact of obesity. And in fact, there's been studies that have looked at how brain age in individuals with schizophrenia, kind of measurement of the structural maturational changes that we see with aging. There's a fast forwarding so that there's accelerated brain aging in a detrimental kind of way in these individuals who have first episode psychosis. And so we know that people with first episode psychosis come in on average with a higher weight and are more likely to be obese. And the complications of that obesity may be to accentuate and exacerbate the problems with neural pathways in schizophrenia and how those work for both brain structure, but more importantly, brain function, because we also see this relationship with cognition and other aspects of schizophrenia.
So that's fascinating. We're going back a little bit to Kraepelin, who called this disease dementia precox. Obviously, it's not called dementia precox because this is only a subdomain of schizophrenia, but still, both the illness, but also obesity, which might be related to the illness, can relate to worse cognition, which a recent meta-analysis has shown. You mentioned the increased brain age, and there's also a decrease in functionality when there's less cognition available. So hopefully, as we treat cognition, but also treat obesity, we can help patients improve their functionality.
That offers such hope, doesn't it? That if we can address the underlying physical comorbidities, we can potentially affect the trajectory of the illness, reduce disability, reduce these complications. So I see some hope there that this is actually exciting opportunities to, if we're targeting obesity, if we're targeting stress reactivity, we may actually be impacting the illness long term. I think that.
Right, but that means that clinicians that are in mental health need to also wear another hat and address, or at least orchestrate, the care for physical health issues. And we'll get to that at the end of the program. So there has been some controversy over whether antipsychotic treatment is associated with increased or decreased mortality in people with schizophrenia, and if there are clinically meaningful differences between specific agents and routes of administration. And that obviously would be very important for clinicians' choice of treatments. So what has some of the literature shown, Diana?
I think, at least for me, it was a surprising finding that antipsychotic adherence is associated with reduced risk of mortality. Because, of course, clinicians are concerned about side effects of antipsychotics that may increase risk of weight gain and metabolic syndrome. And we know we've known about these and we're very concerned about these. But the more we can do to enhance medication adherence, the better individuals do in terms of their physical health. And so so people do better have reduced mortality on long-acting injectable antipsychotics compared to the same oral drug. And regardless, individuals who are treated with antipsychotics do better in terms of their mortality than individuals who are not on antipsychotics.
And it's fascinating. It's not just all-cause mortality, it's mortality due to suicidality, but also they die less of cardiometabolic illness. And that has to do with a recent paper where we were able to show actually that in a within-subject design, that in Finland, patients, when they were on antipsychotics, they were also on treatments to address cardiometabolic complications, anti-diabetic drugs, antihypertensives. And then when the same people were off antipsychotics and stopped them, they were also less likely to adhere to medications that helped them physically. And that can relate then why antipsychotics that can have some cardiometabolic side effects ultimately reduce cardiometabolic death rates, because patients are cared for better when they're not as sick. And I think that's new findings that make sense at the moment. But there's also an interesting to note that while individuals with schizophrenia may have an increased cardiometabolic burden, we do not necessarily see an increased frequency of screening and management of cardiovascular disease. And that's really quite problematic. So even though schizophrenia and the medications for schizophrenia increase cardiometabolic burden, mortality, and morbidity with cardiometabolic issues, they are not screened as much as the general population with less risk factors, and they don't get as fast or as much interventions, either cardiac or others. And therefore, the medical profession also contributes to some of the increased mortality rates because there's some suboptimal care. So how do you think then should we act to decrease the burden that is imposed by medical comorbidities and schizophrenia? Diana, what are some of the strategies that we can incorporate to mitigate these risks?
So to your point that when patients with schizophrenia are clinically stable, they'll do better in terms of their medical illness. So I think it's paramount as psychiatrists or persons who are prescribing these medications to do everything we can to ensure medication adherence, that in the long run, that's going to benefit the mortality of persons with schizophrenia. And we see that when individuals are using antipsychotics and adherent to their antipsychotics, they just do have a substantially decreased risk of discontinuation of statins or antidiabetics or antihypertensives, whatever their medical drugs that they need. They're just more likely to be taking them and more likely to do well.
Absolutely. So I think we need to conceptualize schizophrenia and severe mental illness as both a physical and mental health condition, and we need to conceptualize mental health professionals as being able to orchestrate the care. So in a blueprint paper in Lancet Psychiatry, we actually looked at issues and actions in people with severe mental illness. So there are elevated rates of smoking that contribute to poor mental health and physical health, suboptimal prescribing and unmanaged, unmonitored side effects, as well as medical conditions, and inadequate health promotion initiatives in these patients, leading all to an increased risk. What do we need to do? We need health policy addressing behavioral risks and early intervention, not just for psychosis and prevention of symptoms of the illness, but also for the physical side of it. So basically, we need to keep the body in mind when treating people with severe mental illness. We need to improve prescribing by having a starting point of medications that are less severely associated with cardiometabolic and other side effects. But we also need to have medications, as you mentioned, Diana, that actually have long-term efficacy without being interrupted without our knowledge. So long-acting injectables, as you very poignantly told us, are associated with less mortality than oral drugs because people are on them more. And we also need to, I think, start using more digital health apps so that we can help patients monitor their own health, and we can also help monitor theirs. And finally, we need to address the fragmentation and lack of access of care, especially in people with severe mental illness. And that's especially important now during and after COVID, where we will have, again, some patients that are discontinued from care anyway, being even more discontinued because of poor accessibility of the care that they need.
It's frightening times. I agree. And I think part of what you're talking about is that we need to be doing a better job at monitoring these basic health parameters and intervening either ourselves or referring patients to other programs that can perhaps help the person with, for example, weight loss. And when individuals are taking their medications, when they're clinically stable, they're just better able to participate in those kind of programs.
Absolutely. So you discussed the relationship between obesity and schizophrenia. You just said that monitoring is important. So what are some suggested algorithms to monitor antipsychotic related weight gain and then address it?
Yeah, and so I think it's pretty straightforward to weigh patients. And in these days of telehealth, I actually ask patients to weigh themselves and they report that number. And I am still monitoring it, even though they're not coming into the office. And I think that's important to do every visit. We need to be catching that in at least within the first month of treatment with an antipsychotic, because it is much easier to prevent weight gain than it is to encourage weight loss, right? We all know that prevention is much, much better than it is any kind of lifestyle intervention program. People can lose weight, but that's a challenge for everybody, including people with schizophrenia. So monitoring at least on a monthly basis is absolutely critical. Beyond weight and BMI calculation, it's good if you can get a waist circumference. Certainly we should be doing a better job at monitoring blood pressures as well, and getting either fasting glucose, or I think a little easier is hemoglobin A1C. Because it's sometimes hard to get fasting labs, and also looking at lipid levels, so especially triglycerides. So these are the important parameters that should be monitored at baseline and monthly, let's say at 4 weeks, at 8 weeks, and then at 12 weeks. So that's an example of a frequency algorithm for monitoring these parameters. And then if you do see elevations in weight, then you refer to a program that can help with either weight loss by diet, nutrition counseling, or increase activity levels. Or I do these interventions myself. I actually really enjoy this part of my clinical practice is working with patients around their physical health. And so I think that's something that clinicians really can do, even with brief medication checks.
Just to recap, very important for the audience. So you would do monthly weight checks, because especially in the beginning of treatment, the early weight gain predicts later weight gain. But people don't die of the weight gain, they die of the metabolic complications. So the hemoglobin A1C, even better than the glucose, which goes last when you have fasting glucose going up. It's much earlier, the hemoglobin A1C postprandial going up, and then the lipids. But that you would do at baseline 3 months and then annually, unless you have a lot of weight gain, correct? If there's at least 7% of weight gain, that triggers, again, do some of the lipids and the glucose assessments. And if that's abnormal, do a healthy lifestyle intervention, or maybe if there's hypertension, dyslipidemia, diabetes, maybe refer to a medical specialist. So we need to orchestrate that. Even though we talk about the brain, we also need to look at all of the other aspects. But you said, as a psychiatrist, you enjoy that because it's a whole person approach And in my experience, patients and family members even appreciate that. But another strategy to help prevent obesity and adverse metabolic outcomes is actually to also switch medication from a higher to a lower risk antipsychotic. And there are meta-analyses showing that this works, but you also need to obviously keep patients stable and find medication that they can both tolerate and that they work for them. But Diana, collaborative care, as we just mentioned, is integral if we want to achieve this. And we can't do it all. I don't know the most recent treatments for diabetes and hypertension. We have to pass that on, but we also need to somehow help patients navigate the system. So what's your recommendation there?
Right. So some of the challenges I know clinicians face is just a lack of resources in terms of referral. But clinicians should be paying attention to what resources may be available. And they may actually be surprised at programs that are available in their community that they can refer patients to that can improve lifestyle contributors to the metabolic syndrome risk and the other types of problems that patients have. You know, smoking cessation, that can happen in first episode patients. And we know COPD is a leading cause of death. So within this kind of collaborative care model, we can be interacting with the patient and with other healthcare providers, as well as with the carers of individuals with schizophrenia, who can support our patients in their desires to make lifestyle changes. But there really needs to be system changes. I know in the United States, that's a particular problem. And I'm a little envious sometimes of our European colleagues where there's much more emphasis on preventative healthcare. And I would like to see that happen in the US as well. And so I'm aware of the challenges, and clinicians are going to have to be creative to address these kind of problems, I think.
But you just mentioned there's the macro system, which may be hard to address, and we still need to do that also as a profession. But there's also the micro system, getting family members, friends, significant others in the boat, and that they do the healthy lifestyle behavior with the patient. It's much easier than having to do it alone. So getting them on board, both for the pharmacologic treatment, that they don't undermine it, but also for the physical health evaluation and treatment. That's really important. So thank you so much for this great discussion on the impact of comorbidities on morbidity and mortality in patients with schizophrenia. Are there any concluding remarks that you would like to make?
Well, we know that patients with schizophrenia have a reduced life expectancy. We know that there are many factors that are contributing to this. Some of it's probably inherent in the risk factors for the illness itself, but there are also social circumstances, lifestyle factors, and treatment effects that are contributing to this higher rate of medical comorbidity. And we need to do a better job at identifying and implementing strategies to mitigate cardiovascular risk. And a key part of that is keeping patients stable so that they can fully participate in these programs.
That was a wonderful summary. Thanks so much, Diana. So with that in mind, let's wrap up with our SMART goals. That is, actions that we hope you, our audience, can use in their practice. They are on a global level to detect, prevent, and mitigate. But let's go into detail. What do we need to detect, Diana?
So we need to first understand that every patient we see with schizophrenia has an increased mortality risk, an increased risk of comorbid medical disorders. So we need to be treating patients with schizophrenia as a multi-system disease. So we need to be monitoring for these cardiovascular risk factors, and we need to be monitoring the effects of our drugs on cardiovascular outcomes. This is also why we need to be monitoring for adherence to be able to detect the poor adherence, intervene so as to prevent this known risk factor for increased mortality.
Yes, so detection is really important, but we shouldn't stop there. You just mentioned prevention. So what do we need to prevent?
So first of all, we need to do our part in prescribing medications that have the lowest risk for cardiovascular or health-related side effects. So we know there's differences in profile. We definitely need a drug that's effective, but we need the lowest risk alternative, and we need to consider switching if these side effects emerge. Key, though, is assuring effective and uninterrupted treatment if patients are not going to be able to participate in their physical health well-being unless they are clinically stable. There are medications that have been shown in meta-analysis to perhaps prevent weight gain. Examples like metformin, for example, where there's a relatively strong evidence base. And also we need to be identifying and recommending behavioral interventions such as smoking cessation, diet and exercise counseling to our patients, at least pointing it out to patients and engaging carers in that preventative strategy.
Yes, and finally, not only detection and prevention, we also need to mitigate. So to keep the body in mind, recognize the emergence of comorbidities when they are there or emerge, when our medications might contribute to this, and orchestrate collaborative care with medical specialists. Well, this has been the first episode of a 3-part CMEO snack series on overcoming barriers to the use of long-acting injectables in schizophrenia management, because every patient deserves recovery. Please join us for additional episodes in this series as our colleagues address the role of long-acting injectables in getting your patients to remission and recovery as much as possible, as well as racial disparities are addressed and addressable in patients with schizophrenia. To collect your credit for today's activity, you can click on the link to complete the evaluation. You will be able to print your certificate from the platform. Diana, I would again like to thank you so much for your joining me today for such an important and wonderful discussion.
Thank you.
And of course, I would like to thank you all, our audience, for participating and for providing the best care for patients as much as we can. Take good care.